So indeed, it is my great pleasure to welcome you to the panel 2 that will discuss building of the national early childhood intervention systems or strengthening these systems in countries where they already exist. My name is Aleksandra Jovic. I'm early childhood development specialist working with UNICEF Regional Office for Europe and Central Asia. Building national ECI systems, supporting quality of services is really at the heart of our programming agenda in early years. And we are very fortunate to have our colleagues and offices across 26 countries of Europe and Central Asia region. And our colleagues also work with the national partners, government, civil society organizations, academia, day to day, trying to make the reality for young children with disability better. I have a special honor today to moderate this session, to present a little bit, and we have a very special panel of stars and countries that have made progress in the area of early childhood intervention. We know that each country in this region is searching its own way to plan, develop, and improve ECI services. Each country has its own cultural, economic, political conditions and priorities, but all of them are committed to building ECI system. Lessons learned, as you will hear from more advanced countries, suggest that the best way ahead for countries is to really start on building on the resources that they already have, to define the roadmaps that will help them identify what are the key steps towards building these systems, what are the building blocks that enable provision of affordable, quality, family-centered ECI services. And today we have representatives from the governments, because even in the previous panel in introductory speeches, you've heard we lack funding, we lack policies, we lack services. So we are very happy that we have national policymakers from Albania, Bulgaria, Bosnia and Herzegovina, Croatia, Greece, Kosovo, Moldova, Montenegro, North Macedonia, Serbia, Ukraine, Turkey. A very special and warm welcome to all of you. And we hope that we will have a joint discussion on the way forward after this panel. We will start by setting the scene, and this setting the scene, I will have help from Camille Roux from Co-Face Families Europe and Flavia Shehu from Down Syndrome Albania. And then we will have the panel with 4 countries and their members. And without further ado, let me invite Camille, who is a senior policy and advocacy officer in Co-Face Families Europe, to start with her presentation that will position ECI as a part of holistic family support.
Thank you. Can you hear me? Sorry, I have to step a bit aside because the stand is a bit too high for me, but I hope the interpreter can hear me. Everything is okay? Yes? Okay, great. So thank you, Aleksandra, for the introduction, and thank you to the organizer for having us here today. My name is Camille Roux, and I work as Senior Policy and Advocacy Officer at Co-Face Families Europe. And as Aleksandra said, I'm gonna invite you to take a step back with me and reflect on how ECI is part of holistic family support. So just for you to know who is speaking to you and where I'm speaking from, my organization, as I say, is called Co-Face. We work mostly at the European level, but we can count on the expertise of our members working in 23 EU countries. And we have a specific working group on disability that has been working for more than 25 years to boost the inclusion of persons with disability and their families. So I want to start by setting this scene by answering a question that seems obvious, but is why family of children with disability need ECI? And I want to answer to this question by using the word of the families themselves. So now, words to family, family carers, and ECI. Because I'm going to talk about family carers, I just want to take a few seconds to define what we mean by this term. So you may have come across the term of family carer and informal carer. We are just talking about the non-professional that are going to cater for the care and support need of someone in their that is close to them, so in their family or in their vicinity, and they're going to give this care on an, as I say, non-professional basis. on a regular basis, and that can be temporary or permanent, but that's what we call the family care, is the primary care for a person with care and support need. So in 2018, we asked through our network to the family care, what are the challenges that you are facing and how can we help you to overcome this challenge? And overwhelmingly, the response we got was about the lack of support that family of person with disability have. And the lack of support generally came into mainstream. So the lack of rights they have access to and the lack of support services. So lack of social protection and lack of community-based services. And what is the result of that? Is that the parents, and more often the mother, because this is a very gendered topic, have to leave the labor market or to reduce drastically their participation, which carry with it a lot of risk of social exclusion and of poverty. Because of course, if you don't have the structure, like we heard in the previous panel, to help you care for your children, if you don't have access to inclusive early childhood education and care or inclusive education, you do not have simply the time to engage in paid work. So the consequence of this is, of course, as I say, poverty, isolation, and social exclusion for the entire family. They face financial difficulty because they have to, well, face the disability-related expenses on lower income, but they also face social exclusion because they do not have time, they do not have the energy, and they live in society that are inaccessible to their child, so they just cannot engage in daily activity. So these are the challenges I wanted to highlight, and what was the answer that the family gave in terms of which kind of solution should we put in place to support them. So the solution were various, but they have some common elements. The first one was multi-generational. As we've seen, the family are facing a lot of barriers. So it's unrealistic to think that we can support a child with disability if we do not address the barrier that the family is facing at the same time. Second, they wanted solutions that were family and person-centered. No two children are the same, no two family are the same. And I think you heard Irene explaining in the first panel, that is what we are talking about when we are talking about family-centered ECI. And the last element of response they gave us is they wanted to have policy that address their need and challenges in a holistic manner. So now I wanted to reflect with you on how ECI sit in this holistic family support system. So what do we mean when we talk about holistic family support? We mean the three pillars of support. So that means resources, services, and time arrangement. If we look at resources, here we have a mix of universal and specific measures. So for example, support for parental employment, as we've seen, but also some targeted measures. So for example, help to face the disability-related expenses. When we look at services, that's what the family were asking, is to have access to quality, available, affordable services that are in a community and family setting. And as for time arrangement, is of course measures that are for good work-life balance, and at the same time still targeted measures such as parental leave and universal parental leave and targeted such as carer leave. So reflecting about ECI and how we were learned this morning, it seems quite clear that ECI sits under the services pillar. But after all we hear, it's actually becoming clearer and clearer for me, because we are talking of the principle of affordability, that it can also help to boost the resources pillar. We are talking about the fact that there will be one caseworker for one family instead of going around all day and taking the transport. So it can actually support the third pillar of time arrangement. So that's a bit how we need to think about holistic family support. But now I think the last panel, we were talking about what do we do in terms of policy. So I wanted also to share, to conclude, a few principles of how to think about policy making and integrated policy making in order to make ECI reality. So at COFACE, we very much believe that a disability perspective should be mainstream in all policy. What we mean by that is, like, it's great that we are trying to advance with the disability sector, to advance and to improve the well-being and the life of family, but principles that we are familiar about because we work on the sector, such as universal design and accessibility. Well, we need to ensure that they are mainstream in other policies. Someone was talking about transport. If you do not have access to accessible transport, you are not included in the society. You cannot. It's great to have inclusive education, but if your child cannot take the school bus, it's not gonna be a lot of help, right? And the second is to break silos. So we studied recently the EU social policy, and we realized that in the child-focused policy, there were not a lot of mention of children with disabilities. And in the disability policy, there were not a lot of mention of children. So this concern of children with disability and this partnership with the family need to be integrated in all policies that are trying to address the challenge that the two groups are facing, because children with disability are at the intersection. So for example, when we are talking about early childhood education and care, when we are talking about deinstitutionalization, the family are going to be the ones supporting the child in this process. So if you do not support the family, you're missing a link. And the last one is raising awareness and visibility, because we all know about children with disability in this room, but our colleague in ministry, your colleague in ministry in other services might just not be aware of, or might not think about this when they think about policy. So the more we talk about it, so after this conference, just go talk about it, go on Twitter, try to raise awareness about what we are talking about here, because the more you know, the more we're going to be able to advance. So yeah, thank you very much.
We are continuing, and the next presentation will be delivered jointly by me and Flavia Shehu. And Flavia is coming from the Down Syndrome Albania. She's a PROPAC Service Center Director with background in clinical psychology, and she leads the assessment team and service center programs and parent support programs, and she will join me in the second part of the presentation. So we can start, and Camille had helped me a great deal not to spend time on this slide, because this slide meant only to remind us that although today we are talking about early childhood intervention, we cannot forget that this is only the second box in the broader ecosystem in which we need enabling environment and support to policies that will provide other provisions for children with disability and their families, and that go across all social sectors, and that include developmental monitoring across the life cycle, healthcare and specialized services, social protection, and many others, as Camille mentioned. We shouldn't also forget, when we are having in mind now, how do we build systems? What do we want to build systems for? And in the previous panel, you have heard what are the characteristics of the contemporary early childhood intervention services that we want to see in the future. So we are building the system that can support this integrated social model, family-centered provision in the natural environment of the child, delivered by transdisciplinary teams. Emily kindly reminded us as well in the keynote speech that we are in a transition. Whole life is in a transition. Change is the only constant. The same with the early childhood intervention systems. We are somewhere going from the legacy models in which the full burden of support to disability was on the health system and medical professionals. With evidence that we have, we are recognizing that it is a shared responsibility, and that the families are the most empowered if we support them to move towards the social model of support that is actually based on the family strengths. We also should have in mind what are the key elements, key steps of the ECI service provision process, because the system needs to support with adequate provisions each of these steps. Do we have elements supporting early identification of risks, delays, and disabilities, comprehensive assessment that will look at the child and family situation and strengths and issues, provision of services based on the individualized family plan, and again, very smooth transition into the inclusive early childhood education. This is the slide that I will spend the most time on, because it is a very nice one-slide picture of all the questions that we need to think of when building or strengthening national ECI systems. It was developed by Dr. Jose Boavida from Portugal, and it starts with defining at our national level, what is early childhood intervention? What is this conceptual model? Are we all aligned to the understanding that we are talking about today and sharing, that we want contemporary, family-centered early childhood intervention? Do we have that consensus among all the line ministries, all the actors, academia, parents, civil society in a country when we start building it? Second very important premise is how to build services that are available, including in geographic proximity, affordable, based on interdisciplinary work, and based on diverse service providers that are best suited to respond to the family needs. Third question that you see, what are the resources that we have now, today? Better times will never come. So these steps assumes that we look through careful analysis, as again, Emily mentioned, through the situational analysis or where we are today. Who are the professionals that we have? Who are the institutions holding the mandates to build this system, and to start pulling them all together? What are the professionals that are available? What are their professional competencies and backgrounds? What are the structures at all levels of governance, starting with the national level? Who are the line ministries that should be part of the national planning committees, starting to talk about how will the system of ECI look like? Mirroring the similar structures at the regional level, and then coming to the local ECI teams. Who will be the members of those teams? Where will these teams be housed? And in this process, I'm mentioning government, but government is not the only ingredient. Success only comes if these processes involve parents from the first day and build strong bonds with parents of children with disability in building understanding. Why are we changing the paradigm? Why are we shifting towards this contemporary ECI service? They need to include academia from the very beginning. Not necessarily academic colleagues and professors will have close at their heart these new approaches. But as members of our teams, they will build the common understanding together with us and be able to support new generations of ECI professionals. Question 5, who pays for what? Crucial question. We know from evidence that we have almost 17% of children in the general population that will require more or less intense type of support. It is 20% almost of the population, 1/5 of the population. There are very rare systems who can withhold this pressure. So we have to be very cognizant and careful in how we design it so that, as we said, it is available and affordable to every child and every family. Who should receive services? Eligibility criteria also defining, we are starting now, who are those who will have access? Who will those who have primary access? We've heard in the previous panels as well how important is continuous professional development, building of the qualifications, making training opportunities available both through in-service and pre-service training. Who will be those trainers? What are the programs that are available? How do we build them? And finally, but not finally, what are the quality standards of service provision, of professional competencies that we want to have in place? And there are no numbers on these questions, as you see, because different countries will address them maybe in different order. What is very important is that they are all addressed and that they fill in what is this middle, the vision, the strategy, the policy, the law, whatever you action plan, whatever you as a country stakeholders define will be the founding element for the future steps in the process. And this is, we will shorten it. This is in order to help all of these efforts, because this is not an easy task. It is a very difficult task. We will hear Portugal, it took them 20 years to build a system that they are proud of today. But it doesn't mean that we shouldn't start today or even yesterday. So in UNICEF, with our partners, many of them, RISE Institute, URILAID, EASPD, have developed a set of resources that can help you in this process. Different case studies, the roadmap of 10 steps on how to build the systems, competencies of service providers, standards of quality services, policy briefs. You have all these documents in the app, in the part with documents. Please let us know what is else that you need that could help us. Also, the learning course on foundational ECI is coming soon, and you can check Learn ECD platform to know more. Flavia, please.
Thank you and welcome. As Alexandra mentioned and went through the roadmap of ECI systems, I will go through some challenges that all the countries that already have established ECI system went through, but also countries that did not have yet established ECI system will go through. Which are the main areas of challenges? The first one is the early identification of developmental disabilities, but also putting some focus on children at risk to develop a disability. This is the main issue. The second thing is shifting the attitude of professionals towards family-centered ECI and not child-centered ECI. The third one is the quality of service provision, which for us is a very, let's say, challenging, but also important one in order to provide the best service possible. And the last one, but not the least, is the referral system towards specialized services and transition to ECI education, but also to specialized services. If we go in detail, we talk about few service institutions and organizations which conduct comprehensive development assessment, because the assessments tend to be much more focused on clinical issues or therapeutic issues and not to assess the whole family and the whole system of the family. Few service providers develop individual family service plans, but the focus is always the individual educational plan for the child. Few service providers involve parents in ECI services, so they work directly with the child and the parent is just the receiver of the information, is not part of the information. And there is no continuous system of pre-training and in-job training for ECI professionals. And supervision, which is a very important part, supervision and monitoring in job. So there are a lot of workout solutions and what we have put in the presentation. The first step is to have a national model of service provision, which is very important for everyone to grasp. Clear competencies of national and local government. In case of each country, there must be just one body coordinating the whole ECI system in a country. All in one government processes and tools. There should not be like everything everywhere, but all in one for professionals, for parents, and for the all stakeholders. Empowering families, increased information of families and shifting their mindset toward family-centered ECI and not client services. Mobilization of family resources and the increasement of the resources for all the families to have some, let's say, access in them. Professional education and training for all the professionals working in ECI field. And shifting the approach towards families. Family comes first, establishing the national referral system, not only for children with disabilities, but also for families that are assessed to be families that the child there has a risk to develop a disability. And the last one, which is really the most important, strong standards of service provision. Thank you.
Thanks so much, Flavia. Thanks again to Camille for helping us set the scene. And now I invite through stars of the panel, representatives from 4 countries, and I kindly ask them to join me here in the chairs. I invite Marit Rekuš-Volekbreg, who is coming from the Netherlands, who is a medical doctor of public health working in youth healthcare, who is specialized in very young children with developmental difficulties and children who are very premature. Please, Mari, join me. With us, we also have Miguel Sousa Valles, who is coming from Portugal. He's Secretary General of CECD Mira Sintra in Portugal, non-profit organization that provides services for persons with intellectual disabilities, but is also part of the national intervention system in Portugal for the last 23 years. Thank you, Miguel. Liana Orlika is coming from Georgia, from the Georgian Coalition for Early Childhood Intervention. She was one of its co-founders and is the director of NGO Bridge for Social Inclusion. And we have Sneža, applause to Lika. And we have Snežana Ilić coming from Serbia, where she is the assistant professor at the Faculty of Special Education and Rehabilitation, but also member of the Special Working Group of the Ministry of Health for the implementation of the National ECD program, trainer, mentor for ECI, and the board member of UNICEF. We have asked all of our panelists to prepare 2 slides that will give a brief overview of how does the system of early intervention look like in their country, so that you have the better idea what to ask them afterwards. I have some questions, but I hope that we will have time for some dialogue and that you can hear more about their direct experiences. So Marit, please, Marit will tell us a little bit more about the system in the Netherlands.
Yes, thank you. Thank you for the invitation that I'm here. And as Alexander already told, I'm a doctor of public health. It is like a pediatrician, but it's just a little bit different. And I'm going to tell you in a minute what it means. But first, I want to tell you a little bit about the Netherlands. The Netherlands is a small country, just slightly bigger than Albania. But we do have a lot of people living there, like 17 million. And we do have about 170,000 children born annually. And 80% of these births are going well, but about 20% has some problems, like they're born premature or small for gestational age, or they have congenital syndromes, or they have a hard start, like oxygen problems. And these children are more likely to develop disabilities, so they need extra help. And to show about what we do care about the children, all children live with their own families, and I think it's up to, it's really small, up to 0.005% of the children up to 4 years live in institutions. And when they go to school at 4 years, I think 95% of the children go to regular schools, but we also have special schools for children with disabilities. So about the Dutch ECI system, we do not have a national program for the ECI, but we do have different programs. And as I told you, I'm a doctor of public health. I work at the health services of the municipality, and it's called the youth healthcare. And here we provide care for all the children. As soon as your child is born, you have to register at the municipality, and we get a sign. And the nurse will call the parents like, congratulations, your child is born, and we would like to meet you. And the nurse will do a home visit at when the baby is about 4 days old. And they will do another home visit when it's 2 weeks old. And then it's really in the local area. And then the parents will come with their babies to the local centers where we are as a doctor and a nurse. And we do check up the baby for the medical checkups, but also for development, the social part of it, and to see how it's growing. And we do the vaccinations. So this program is voluntary. But we do see 99.2% of all children in the Netherlands because of this system. And this system already exists for over 100 years. So it's really common that you go to the youth healthcare. So this is for all the babies. And actually, this is really nice. This morning, we had already some presentations that we start at when the child is born, but actually, we had a change in the law last year. So the youth health service already starts doing pregnancy now, because we know that it's really important. There's no stress with the parents when the child is already growing. So we start at -9 months now. So this is there for all the children, but we do have other programs as well. And it's called Youth Help. And Youth Help is there if indicated. And there we have psychologists working and social workers to support the parents. And since about 8 years, I think they changed the model because it was only indicated, but now it's also preventive, like youth healthcare. They're in the same teams now. For parents, if they have any questions, they can go to youth help. It's preventive care. And if it's needed, they can also give more curative care and also do research and help the parents and guide them. And then also we have the insurance care, and that is with the speech therapists, general practitioners, physiotherapists, and also the pediatricians. But it's really only on a referral that you go there. So we all have 3 systems, and they all have their own laws, their own financials, and their own standards. But together we try to get the ECI together. And of course, we have NGOs as well, and they are really important. They don't have a huge role because we have professional settings, but they are there to connect and to support and create awareness. And I think it's really nice that they're doing really well. For instance, I think we had a commercial lately. I don't know which it was about, some internet services or something. But in this commercial, there was actually a child who had Down syndrome. And she had a big role because she was assisting her little brother. He couldn't turn on the television or whatsoever for the internet, and she helped him. So I think it's really nice. And that's really because of the NGOs do a lot of work. So even children with Down syndrome are really part of the society, and we can't work without them. So what I told you about the youth health system, we look at a child and its environment, because it's always also in the speech of this morning, you need the child, but it's really important with their environment as well. You have the parents, they have to take care of the child, but for instance, also when the child goes to daycare, to childcare, we'll go there and do an observation how the child is behaving at childcare. And as soon as we see something in the development that is not going how it is supposed to be, then we ask the youth help and ask the insurance parties as well to think with us as a multidisciplinary team. And really important, the parents are part of that multidisciplinary team as well. So this is how we try to organize, but as I told you, with different laws and different finance, so it is still hard.
Thanks a lot, Mari. And we pass the word to Miguel. And yes, of course, please. We hear the story of Portugal.
So good morning, everyone. I'm Miguel from Portugal, and thank you so much for all the presentations so far, because it made my work so easy, because we were so inspired by Emily and José Boavida, that is our national coordinator, and made things really easy for me. So thank you. Where do we start it? So everything started from the UN Convention. So Portugal faced the UN Convention as a mandatory convention that Portugal is obliged to comply with. It was not seen as optional or something that could be later discussed. And through the signing of the UN Convention, a major shift occurred on early intervention and on inclusive education. For example, by signing the convention, all special schools were asked or motivated to transform themselves, to become resource centers. And after 3 years, all special schools, most special schools were closed. And so the inclusive education in mainstream public schools occurred because there was a convention there. So this was, for me, the tipping point of a major shift, a major national shift that was addressing a very realistic and non-optional way. So it started from there. we had a service also as a early ECI service based on rehabilitation model. So I'm a therapist, and our team were therapists. Other teams existed on the health sector, on the social sector, and the education sector. And by reforming the system with mainly all the academic papers, all the evidence base that at the time was gathered, 3 persons were selected. So 3 champions of ECI and inclusive education were championed and represented at a higher level of the ministries. So you have champions on the Ministry of Education, Health, and Social Affairs or Social Security. And then from there, a whole system could be designed. So it started from there. And what was seen is that it was not a cost-effective thing that we are doing. Portugal is a poor country. It has very limited resources. And from there, you could see that Portugal could not afford to miss on early intervention because the costs on the long way were enormous. So it was a choice. It was a national discourse and a national discussion on what is the priority. And ECI was clearly seen as a priority, so that later all the resources that spent on adult education and occupational centers and institutionalization could be more easily addressed. And this was how we viewed things. So what we wanted to build was a national system that, well, all 3 ministries could participate in every level of national coordination to regional and then to local teams, a very cost-effective and long-term system where the team has the good and the bad side of representing 3 ministries. So an ECI professional, when approaches a family, when approaches a service, he represents 3 ministries behind him. So it all good things and the bad things also, because each ministry also has its bureaucracies and challenges. And the system could, at the national level, it would cover all territory and it would be free of charge for the family. So this started from there, and by enabling competencies of parents on occasion of a second child, services would probably be less required, and this was the rationale behind it. So the premises to construct our national system was to increase the learning opportunities of the child, to strengthen caregivers competences. Caregivers here can be families or the service or the place where the child spends the most time in an active way. And of course, promote family and community resources. So this is we have a single national coordination represented by those three ministries. We have regional subcommissions. We have 5 because Portugal has 10 million people, so it's easier to accommodate this regional. And regional subcommissions are also in their work description to provide supervision on the local ECI teams. So at the end, we end up at 154 local ECI teams. We are one of those teams. We have 16 professionals working in the same team. So a doctor, a nurse, 8 teachers, therapists, and this is the team. The national system supports roughly 80,000 children with disabilities or in risk of developing disabilities. So there are environmental factors that turn the child eligible for support, and this is really well defined. Thank you, Alexandra, also to present on José Boavida framework, because it's very clear what are the eligible criteria to be integrated in the system. And here it's sorry, it's a bit of a mess, but it's our framework. So from start, we have the screening process where we can see that if it's eligible, the child, or not. If it's not eligible, maybe other teams and other resources could be activated. If yes, okay, then we start to move on. We select a case manager. So it's not, we do not select a therapist or a teacher. We select an ECI professional. So me as an occupational therapist, when I work in this environment, I'm an ECI professional. And that's the way I present myself to the families. And I'm there not as previously as I started as this professional to tell families what they have to do, but I approach families to say, how can I help you? So on the issues that concern you, on what is my role as a facilitator, because this process is family-led. It's the family that decides what are their plans, and I'm there only to accommodate that. And imagine for a family that previously had to go to a center, had to go to the hospital, then had to go to the school to deal with all the problems. There, since I represent 3 ministries, everything could be done through me. So for the family, it's very stressful free. It's less stressful, sorry, not stressful free, but it's less stressful than try to interact with so many systems, so many rules, so many regulations, and different prerequisites. And for this the center is the transdisciplinary team that tries to accommodate all these requests from families. And so I understand that this model brings a lot of questions, and I will be delighted also to answer them. Thank you so much.
Thanks a lot, Miguel. And passing the microphone to Liana from Georgia to hear as well how the Georgian, and you will note that there are different providers of early childhood intervention. In the case of Portugal, those are the public system providers. In the case of Georgia, we will hear a slightly different story. Over to you.
Thank you. It's a pleasure to be here, and thank you for such wonderful presentations. It was very inspirational. Regarding Georgian ECI model, I will be talking about how it was developed and where we are stuck right now, kind of. Could you please show the, I have to do it? Sorry. Thank you. Okay, so Georgia's population is around 4 million people at the moment. We have huge struggles with migration, but our ECI model, even though Georgian history is quite ancient, the services do have the Soviet heritage kind of characteristics, and we're still fighting some of the thick layers left over there, switching from medical model into social model. But we're really proud with achievements with our ECI model. There are NGOs providing the services all around the country. The first ECI service provider was in the capital of Georgia in 2009, and nationwide it started in 2012. And I will be talking about what is the number of the providers now on the next slide. So there are NGOs registered at state social agency that are mainly licensed to provide ECI services. And children from 0 to 3 receive all home visits at their natural settings. It could be their homes, it could be their playground, it could be the preschools, kindergartens. Although we can have parent group sessions held in the center, mainly for social skill promotion. But the service of ECI in Georgia is from 0 to 7 years. And we can do half of the, like 50% of the visits at the center when the child is more than 3 years old. We do have as a plan to deduct the age from 0 to 7 to 0 to 5 in the future. But there are reasons why we cannot do this right now, and I will be talking about this more tomorrow. But one of the reasons is because the kindergartens are not really ready to do their part of the job, so we're struggling with that. And the funding comes with the government. Actually, the government named ECI program in Georgia #1 program that they're funding, so they love it now as much as we want, but it was not like that in 2012, let me tell you this. But they are funding all children, whoever is eligible to receive the funding. The budget is usually adjusted annually, and of course the service is free of charge for all families. And they provide 12-month vouchers, like a paper that, for example, the social worker gives the family, and then the families can take the voucher for, for example, January to any ECI provider. But if he or she doesn't want, or the family doesn't want this provider, they can change the provider from the next month. And of course, the team is mostly transdisciplinary, but we do have some struggles with providing main service provider with like a variety of disciplinary team support in the center. So of course, the early interventionist goes and does the like mostly 99% of the visits. But right now we are struggling providing more human resource support at the center for the ECI interventionist. And we want that to change as well. But of course, family is greatly involved in developing IFSP. Regarding identification, children with developmental risks are identified and referred to ECI mainly at child polyclinics. We don't yet have the national screening tool involved and available for pediatricians, but we are planning to do so, hopefully with ages and stages questionnaire or something similar in the future. We are using this tool, but mainly at psychological services or, in the private sectors. But some of the children are being identified at neuropsychological centers. For example, if the neurologist or pediatrician doesn't like certain things and has some difficulties, determining the issues, the child could be referred to this type of clinics, and then the report finally is done with a psychologist or team of transdisciplinary team, and then the child receives the medical form from the doctor. And then the child goes and asks for the voucher to the government. And current coverage is more than 2,800 children of 24 municipalities. And of course, Georgia is quite a small country. And there are 34 ECI service providers, and the budget is more than 1,500,000 euros. We have ECI States program, part of the social rehabilitation and childcare program at the Ministry of Health. And the standards of ECI was adopted with the parliament. And the reason for that was that Malta, Ministry of Health, didn't want to adopt this standard. And we went with the other way. We made the parliament to adopt it, and then they made the government actually to adopt them in their own regulations. And we have ECI team trainings because we don't yet have the bachelor's or master's degree in ECI, but we have like a official certification program at ECI Coalition, the one which I'm representing right now. And this certification program is also adopted, the framework of which by Ministry of Health. And of course, these trainings are pre-service and in-service, and we have main 4 modules. For example, for the person who is a psychologist or educator or somebody who doesn't know anything about ECI, does the first module, and then for you to become a supervisor in this program, you have to do the 4th module up to 1, 2, 3, 4, all 4 modules. So if we have time, I can continue. This is main circle of how the identification is done in Georgia. And this is mainly how we do the ECI cycle, for you just to take a snap of the photo. And I'm more than happy to answer all of your questions in the future. Oh, sorry. So yeah, thank you very much.
Thank you so much, Liana. Thank you for sharing this slide. All the presentations will be available, and remember their faces. So whatever they don't respond to now, we have lunches, breaks. That's why we are here together. Yeah. Snezana is coming from Serbia, so we will hear more about their experience.
Thank you. First of all, I have to say that we need support as a country. We need support as professionals. And thanks to UNICEF Serbia supporting us in this process. And it seems like they supported us in the same way. We are now trying to support our families in Serbia. They are building on our strengths. We somehow identified challenges and set priorities. And that's the way how we are doing with families. This keyword is support. And the first thing we did is situation analysis in 2017. And if we are looking now after 7 years where we are, this is a really huge step forward to family-centered ECI. And also UNICEF Serbia supporting us, and also Open Society Foundation. And after situation analysis, we realized that we have resources. And maybe my message to all of you is like, if you are looking just in challenges or in lack of this or lack on that or fragmentation services, you can do nothing. You have to see what you have, where you are. And because maybe I'm from the university, I'm looking in a science and evidence-based practice, and where we are according to that. We need knowledge. And then after situation analysis, we realized all of these things and choose 2 locations for deep analysis of what services we have. And we realized it is fragmented, professionals doing on their goals separately, not asking parents. Parents are in front of the office waiting for fixing his child and took child and go home. That's not ECI. And also we are realized that we have late identification and we don't have instrument. And thanks to these organizations, we now have ages and stages questionnaire standardized for our country, but still in struggling with process with contract with Brooks and our Ministry of Health. But we have it for our children and our pediatricians. And you can read from this slide, but also base for building system, and the challenge at the beginning maybe is to coordinate and to have intersectoral collaboration. And you can see this on slide, these 3 wheels. It's very important to have together child protection, preschool, and health system from the ministry level to the local level. At the local level, we have resources because at the primary health centers, we have on some locations developmental counseling units. We realize that professionals can support us, and somehow now it is the coordinator place for all team. We have people from all these teams, from preschool, because they are doing inclusive education. We have psychologists, pedagogues, speech therapists as a supporter to children and teachers, preschool teachers there. And we have them now in the teams at local level, together with people from health. I mentioned this developmental counseling units, and people from social welfare at the local level. Then we have now assigned action, call for action for this ECI system from also 3 ministries, and that's how this is how you can do at the local level. If somebody told you you can go out and you can go to the home visit, you can say, but we have a protocol of cooperation and intersectoral collaboration. That's the base. And also how it's going, we have now model, because on these two locations, we created a model for Serbia from what we have and knowledge we got. And I think also key element is knowledge, and we got it from international consultants, Holly Hicks Small at the beginning, then from ANIP, Portugal organization for early intervention. Yearly Aid trained us with a few trainings, and at the end we got the champions from our practice, and also supervised them and made trainers and mentors from this perspective. And from these 2 locations now, after 6 years, we have 19 locations. And just to say, Serbia is a small country. It's like 7 million people, and we have 26 districts. And now we are on 19, still in mentoring process and still in supervision process, but thanks to these colleagues, now we have 3 supervisors. We have, I think we have here 13 trainers, 3 supervisors from academia, and more than 500 trained professionals. When we are talking about capacity building, we can say that we got knowledge about functional assessment, about routine-based interview, some eco maps, and ages and ages questionnaire for pediatrician. Also, we have at our university, because we have now supervisors from academia, now in syllabus and in base and bachelor level and the master level, we have at the Faculty of Special Education and Rehabilitation in the University of Belgrade, have these lectures and building this for the future for our country. And at University of Novi Sad, we have specialization for 1 year. And maybe I forgot something, but I want to tease you to ask. And at like top of everything, we are trying to have this building, but that's not just a building. This is a center for early childhood intervention and inclusion, and that can be a national institution who will support all these 26 locations in the future for supervision, for consultation, for some special diagnostics, and I think nationally, but also regionally can be support to all of these networks, and I hope so that that can be the truth.
Thanks a lot, Snežana, and thank to all 4 of you. And while you think of your questions, I will start with my questions to the panelists. And the first one is to Marit. You were the first. Marit, what do you see as the benefits of the Dutch model? Hearing also from other countries, what would you say are the strengths?
Yes, well, I think that one of the strengths is that we do see all the children, like 99.2%. And we see them from, well, even when the mother's pregnant, till they are 18 years old. We know the families. We go to their houses, they come to us. It's really easy going that they come to us. So we can detect the development problems really, really soon.
And for Miguel, maybe because you are among us, you are the oldest in terms of when you started working not in terms of age, but you also have accumulated, I think, the most of the lessons learned, right? Mm-hmm. In terms of what would you now do differently what would you change in the Portuguese model?
it's not an easy question to answer. What we would maybe do differently was to better prepare academia for training. So it's by design, the whole system is made according to self-training of professionals. So the subcommissions are their task is to train the professionals. We were not expecting such a high turnover on some professionals. For example, the teachers. Many of the teachers, after 1 year, sometimes they are allocated to a school or to another. So there are no teachers are seen as teachers, really, not as teachers on ECI. Another thing was to better prepare the next generation of champions through the ministries. So what I think one big strength of the system is that their political influence, yes, but is made through persons that really have the experience and expertise and the credibility to defend the ECI system at the political level. So nowadays, because the system is going on for 20 years, some of those champions are leaving, they are retiring, and we are a bit concerned that the next person that will be the champion may not be the right person to so it's an ongoing challenge that we have.
But you have legislation in place that also
We do.
protects.
Yeah, we do. We have a really strong legislation. So a ministry cannot abandon a system because, oh, I don't want to participate. No, it's by law. It's designed by this. However, when in practice, you could see if it takes seriously and if it allocates the really good professionals or see us as a secondary option, you know.
Well, I hope that new champions will come. They will
Yeah.
be as strong as the
Exactly.
previous, but
That's
it
so
is
true.
an ongoing challenge everywhere, right? People are changing, governments are changing. So the challenge of really keeping the momentum and communicating on the benefits is very important. So for Georgia, we heard also 10 years of success after you convince the parliament. I really, like this fact. So you see, when there is a will, there is a way. If the government doesn't want it, parliament was the one that adopted the legislation. So you already had some time to see really the true benefits of ECI. I've heard that in Georgia, in the, where you have really active and excellent centers, special schools don't exist anymore, or there are no children who need, this kind of support. What are your first lessons learned?
Thank you for this question. So for these last 10 years, I myself, I am a service provider also, as you mentioned, by Bridge for Social Inclusion. And I will be talking not like the research and evidence-based practices, as you could all hear in this morning, why ECI is so important, but from my own experience, what I have seen. So, for example, we've seen that in 2012, the average referral age to ECI from primary polyclinics, let's say, was 5 years or 6 years. And we know how important it is, the early detection and family involvement. And then we did the research into 2018, and it was 3.5. So it was changing drastically. And we haven't done the research yet, but right now I can tell you that it's under 3. Our goal is, of course, to go under age of 1, and then, during the pregnancy probably. But first, this is very important that the primary referral sources know about ECI, and this is one of the lessons learned, that you have to cooperate, do the trainings, including how to use screening tools, how actually these transdisciplinary team members work, what are the benefits of the families, and also earlier we start ECI, less children will go to special schools, as we call day centers in Georgia. And now only children with severe disabilities or multi-disabilities are mainly in day centers in Georgia. And hopefully we will see that the day centers that are serve children with only, very tiny, small issues will be closed, and then the children will go to primary schools. And actually, we also have the specialized day center program, and we no longer see children coming from ECI to day center, which is a great victory for us. And this is probably the main lessons learned.
Congratulations.
Thank you.
And we hear, repeatedly how important is early identification and how important it is when it comes through the health system and primary healthcare system that sees every child. In most of our countries, we have almost universal coverage. So whichever child we miss to identify from 0 to 1, it's a huge missed opportunities for the child, for the family, and for the society in terms of both economic and societal costs. Snežana, what do you see as victories? I mean, you've told us a little bit already, but you have established a really impressive system in a relatively short period of time.
I think the most important is mobilization of different national and local institutions together in the network, and also intersectoral collaboration. And also, I think paradigm change and this shift in service provision among professionals in all sectors. And all of this demonstrated also in this establishment of the National Resource Center I mentioned. And also, I think we have a huge professional now force and enthusiastic people and champions, and they are building the way and doing things on the enthusiasm now. And we have trainers and mentors, and this is really nice. I was last week in the supervision and one team, and I went through 2 days like in heaven of family centered ECI, because we are talking the same language. We saw families and these results and this trust and this relational and participatory practice, which is ground and one of main thing in family centered ECI.
And they changed professionals.
Yes,
Okay.
yes.
I have more questions, but I want to give you the chance. We were late this morning. We didn't have time to give you the floor. So we have microphones that are walking through the room. If you raise your hand, you will get one. And please be free. We have the hand over there. Just please introduce yourself. Let us know who is your question for.
Hello, ladies and gentlemen. My name is Stefan Baloka and I come from Caritas, Albania. I see myself as someone who fully belongs to this event, to this wonderful event that has got together so many people, so many experts, policy makers, and this is really something I'm so happy that I have not lost. So I belong to this event both personally and professionally. I was born with a very low vision, and that was something that in our times was seen as a reason for the person to be qualified to be registered in a special school. We have just one special school in Albania, just for your information. It is situated here in Tirana, and is the institute for for people who can't see. This is how it is called. And but it was my father's decision not to send me to that school. It is not that he was so revolutionary as to understand the importance of an inclusive educational system No, not at all. We didn't even know that something like that existed. But you know, he didn't accept my situation. So I was really treated very wrong from the beginning. And this was something that has really cost me dearly later in life. Why? Just to give you a few examples, I haven't learned to ride a bicycle until I was 30. I have never written on a blackboard because my teacher said I couldn't, and I had to, you know, start teaching English before I before I could understand that I was able to write on a table, to write even straighter lines than those who have full vision. I haven't been allowed to touch a knife with my hands until I was an adult, and I didn't ask anybody anymore about that. So what I mean is, without a professionally based early childhood intervention, you know, the life of a person with disabilities would be a bit more than a misery. And if I have got over the situation that I have gone through, if I had really, you know, overcome the obstacles created by the society and internalized by myself, I wouldn't be here where I am today. I would be where more than 90% of persons with disabilities in Albania, of adult disabilities in Albania, are right now. And it is not their fault for their situation. It is the society's fault. And this kind of fault, let me be a bit harsh, amounts to a systematic criminal, you know, situation, really, because those people will never become fully people able to get fully included in the society, and so put it into said in the words of a poet of our 1930s, a poet of ours, you know, their potentials will be, because he didn't say potentials, he spoke metaphorically of unsung songs, and he said, deep in myself sleep the unsung songs. So these people might be born and die being the cradle and the grave of their own potentials, and the society would miss their potentials, their contributions, their potential contributions, and that is a big, you know, wound for the society itself. If only society would understand this. So thank you very much for this wonderful opportunity you gave to us. Now, being from Caritas Albania, I am sure I will have a lot to report to my superiors there. And thank you, and I wish you a lot of success in the following hours and the next day. Thank you.
Thanks a lot for your personal testimony, and I hope that we all have enough knowledge and understanding that we will do our best so that children who grow today and who are born today and who need support really reach their maximum potential. We have another question here.
I have a microphone. Hello.
Please go ahead.
I am Revan from International Developmental Pediatrics Association from Turkey. So I have a lot of questions to ask. Thank you all for presentations, but I will ask only one and reconvene that when we have time. So I want to ask Liana about the links you have established between where identification takes place and the system of ECI that you have built, because that's a weak link in many, as far as I have studied, the integration, I mean, from going from ensuring smooth transition from where you identified to services. Many things, bad things may happen there. Can you please expand on that? Thank you very much.
For example, the family takes the child with a cold to the pediatrician, and the pediatrician has the knowledge about child's development, of course, but additionally has training from the ECI coalition or some of the projects that ECI service providers have done recently over these 10 years, and knows how to make a focus on some of the developmental domains rather than just do the checkup. And for example, during this checkup and giving all the recommendations to the family, the pediatrician can also do the developmental screening. We use mainly ages and stages questionnaire, and also not only the physicians, but the nurses of the assistants of those pediatricians are also trained in ages and stages questionnaire, but not in all regions and not in all polyclinics, of course. And they can do it on the paper because they have they don't always have the computer and the internet, although the ages and stages questionnaire is translated and adapted it's not standardized yet, but it is adapted to Georgian population. And it's on the website of the Ministry of Health, and it's easily downloadable, all for all ages from 2 months to 60 months. And so if the pediatrician sees that the child definitely needs the ECI service, the pediatrician can give the booklet or the information about ECI service providers. We also have the ECI coalition website where you can find all ECI providers in any region of Georgia, and you can contact them, and or maybe the pediatrician can give just the number of the organization in the region and the coordinates of this organization. And all of these organizations, mostly at least once in every region, has the great transdisciplinary team that could be reached as a private service, for example, psychological evaluation, or speech and language pathologist consultation, or occupational therapist consultation. And then this child could be referred directly to this center for further evaluation. And then if that evaluation definitely says that this child definitely needs ECI or any other services that is available in the region, then the transdisciplinary team or maybe just a multidisciplinary team member, depending on each case, prepares a report about assessment report, and then with a stamp and all of the main characteristics of this assessment goes back to the pediatrician. And then pediatrician prepares the medical form and directly states that the child needs ECI service. But the pediatrician can do that without sending the child also to this organizations, and can prepare the medical form without any of these assessments or assessment reports. But it's usually more helpful for social agency and social workers to determine the direct need of the child. And then the family is sent to the social agency to write to fill out the document for requesting the ECI service. Also, social workers can visit the family, and not can, but they are visiting the families when they receive their referral during the first month of the referral, and they prepare the report about the family needs, and they also determine that the child definitely needs this program, and they put the child on the waiting list. Sometimes it can, the service voucher could arrive within 2 months, sometimes within 4 months. We've had some cases with more than 6 months in previous years. Especially we struggled during pandemic because all the money from ECI some of the money was, put into the pandemic expenses, but now it's back on track, and we usually receive new children, new beneficiaries each month. And so the child, as soon as the child receives the voucher, the family decides which organization they can choose from. even if the organization was like a different organization prepared the assessment report or helped the child, I mean, it's up to the family.
Thank you very much.
Mhm. Thank you.
I can, well, sorry for intervening. We passed some of those phases also, and now we created in Portugal, for example, a really simple system. Anybody can be a referral person, and that referral is delivered in the website directly to the transdisciplinary team, and by definition, in 15 days, that person is contacted to say, what are your reasons of concern? And then we'll start from there. So we simplified the system so there's no evaluation needed or diagnosis, or it was a concern. So any person can be, usually it comes exactly from health, but it can be anyone. A parent, yes, a teacher, a neighbor.
Can I add something
For-
also to that? It's wonderful. Don't stop. We can put, for example, R 62.0, which is from ICD 10, developmental delay. So it's not a diagnosis.
Mhm.
So I just wanted to make sure that you understand that ECI doesn't need a disability status or any diagnosis. But if the child has some delays in at least 2 domains, then the child is eligible. So thank you for your
Yeah.
Do we have more questions from the audience? We have time for one more question.
I actually just wanted to build on what has started, because it would be really important to understand in Portugal how that you deal with a limited workforce and so many demands as well. You know, how you, because in Georgia, they have a waiting list, because this is based on the availability of funding, availability of workforce, availability to start with an intervention on time. So who decides, and how do you decide, and how you manage that in terms of intensity of support and the quality of support you actually provide to the families, because it's always more needed, particularly if you engage also with families at risk, which is really one of the advantages of the Portuguese system.
Thank you. The decision is made by the transdisciplinary team. It comes from there. So we say that the service is incompatible with a waiting list. It's early intervention, not later intervention. So early intervention, by definition, does not have a waiting list. So if I get a call in 15 days, I must get a response. And by definition, it's this. If there's no one available, I have to check according to the whole team. So we are talking about 16 professionals saying, what is your availability to have at least an immediate interview? And then from this interview, I can see, is there a priority case? If there is a priority case, well, then the team must decide, well, you have to put on, because we have different levels of support. So really intensive support can be every day, you can arrange by this. Every day I have to be with this family. And what the lacking of this system is that we do not have almost like family assistants or personal assistants that will be trained to us to spend, for example, the whole day with the family. That is one system that I would love to have. We do not have that, so we have specialists. And if it's in a priority level, yes, it reaches. It's easier because it's not a coordinator that decides, or it's on the team. And if you see the need, you can say, okay, I have a family that now is being more autonomous, and let me just have 2 more sessions or something, and I will get the case. So it's a very, how do you say it, organic and dynamic situations. I know it's a bit stressful and anxiety, but since you have the support of a whole team behind you, it becomes easier. Yeah.
Thank you so much. Thank you for your questions. A million thanks to the panelists. I think that you see that these are not countries, apart from Netherlands, that are diving in resources or money. But they found the ways to pull together what they had. And the best start for every country is to look, what is that you have? Who are the professionals, who are the institutions that you can pull towards the same vision? And this vision is powerful because we see high gains for children, for families, and for economies. We have economic studies that show that on $1 invested, it is $17 return when we have the most vulnerable groups. And this is the case when we are talking about children with disabilities. So the time is now. And I hope that we will spend this time that we have left together to also exchange more and discuss. And we see you after the lunch. I'm sorry, Timothy will share that.